This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Welcome everyone to our now 15th episode in our UPMC Children's Hospital of Pittsburgh Pediatric Hospital Medicine podcast series. As usual, I am your host, Dr. Tony Tarchichi. I'm a Med-Peds trained pediatric hospitalist here at Children's, and I'm a member of the Paul C. Gaffney Division of Pediatric Hospital Medicine. So first off, I'm going to apologize. It's been 4 months since my last episode, and I usually don't go that long. It's been a very challenging 4 months. In that time, I went to PAS, the Pediatric Academic Society. Some of you were at our workshop, which I appreciate you coming to. There was, of course, PHM, which was a week or 2 weeks ago. It was great seeing everybody there. And then I did family vacations. And now at Children's Hospital Pittsburgh, we have our first Pediatric Hospital Medicine Fellow. So shout out to Dr. Elise Liu, our fellow. And I'm the fellowship director, which has kept me busier than I expected it to. And then other work obligations have also kept me busier than I expected. So we are now getting back into the swing of things with the podcast, and I'll be coming back at our normal schedule should be 4 to 6 weeks. As I just want to remind all of our listeners, there is free CME associated with each podcast, except for our 2 on the hurricanes, that you can go to and get by clicking the link on our podcast description to the University of Pittsburgh site, logging in, and then going from there, answering some questions. So this episode is going to cover the cardiology portion of the newborn medicine core competencies. So before we keep going with that, let me explain. We've been discussing this over and over. Now, as some of you know, the content specifications for pediatric hospital medicine are out on the American Board of Pediatrics website. If you don't know what that is everything they're going to test us on for the boards is on the American Board of Pediatric website. I just Google ABP, Content Specifications, Pediatric Hospital Medicine. You can download it. So we've been kicking back and forth whether or not we should move to them or stay on the core competencies. We are going to finish the newborn medicine section because I promised you we would, and it's been a bear to finish. It's bigger than those 2 pages they put it on. So after that, we're going to decide one way or another whether to move to the content specifications or to keep going with the core competencies. If you have an opinion, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. So this episode, we are going to do the cardiology portion, like I said. So I'm going to start with introducing our expert guests. First off, a friend of the podcast who's been here now a number of times, Dr. Arcangela Balest, a neonatologist in our Division of Newborn Medicine at UPMC Children's Hospital of Pittsburgh. She has a special interest and expertise in feeding. She's uniquely qualified to help us with these discussions in newborn care for the pediatric hospitalist because she has worked as a pediatric hospitalist in our group for a few years and then went and rejoined neonatology. She's neonatology trained. So we're very happy to have her. And our second guest is Dr. Guarav Arora, a Med-Peds trained pediatric cardiologist and electrophysiology trained exclusively at Texas Children's Hospital and Baylor College of Medicine. He's currently an associate professor in Division of Pediatrics here at UPMC Children's Hospital of Pittsburgh. And he's the associate director of electrophysiology and the associate vice chair of pediatrics for clinical affairs for ambulatory care. So Guarav and Ark, thank you both very much for being here with me today. I appreciate you taking your time out.
Thanks for having us.
Thanks for having.
All right. So all of the guests and hosts on the podcast have nothing to disclose. The way I thought we would start is, Guarav, I thought maybe if you wouldn't mind kind of going through fetal circulation and how it changes as you're born. Would you mind doing that? Then we're going to get into our discussion.
No, that's fine. I think that sets the tone for a lot of what I think about in those first 48 to 72 hours of life and what might go wrong. So as you remember, to put into perspective, the normal postnatal circulation is a series circulation, right? So all the blue blood or deoxygenated blood comes back from the body and the brain, goes to the right side of your heart, goes to the lungs, and the lungs gets oxygenated, turns into red blood, goes to the left side of your heart, goes to your body. So all the blood cells that go to your lungs also go to your body. It's a series circulation. So fetal circulation doesn't work that way, right? Because babies in utero don't breathe oxygen in the way that babies ex utero do. So what happens in utero is the circulation is a parallel type circulation where blood goes and mixes in different ways. And only about 10 to 15% of your total cardiac output actually goes to your lungs in utero. And the reason that's important is because the amount of flow drives growth. So we know that the pulmonary arteries don't grow as much in utero as they're going to grow when you're born because they haven't gotten as much flow. And so basically the body has two systems designed to bypass the lung area. One is the atrial level shunt at the foramen will have that blood from the IVC going directly into the left atrium. And then you have your ductus arteriosus that allows the blood that comes out the pulmonary artery to bypass the right and left pulmonary arteries and go directly down the descending aorta. And so as babies transition from fetal circulation to postnatal circulation, the changes that go around the ductus arteriosus and the atrial level shunt, as well as the pulmonary artery sizes, come into play as to reasons why they might have murmurs in those first 48 hours.
Thank you, Guarav. Now, I'm going to be honest with you if you're listening at home. When I first decided to do this, we're going to lead with a term baby who has no issues, looks great, but has a murmur. And when we first got into this, I thought, that'd be the easy part of this talk. And I was telling Guarav on the way over here that we'll pound that out and get into something more substantial like a cyanotic infant born in nursery. Well, once you get into the literature, this is less straightforward than you would expect. So let me tell you what I'm talking about. First, we're going to talk about a paper, Natural History of Innocent Murmur in the Newborn, Controlled Echocardiographic Study, done by Romain Arletaz, Nicholas Archer, and Andrew Wilkinson. This was done in 1998. It's in a BMJ journal called the Archives of Disease in Children in the Fetal and Neonatal Edition. So this was a non-randomized prospective trial done to define the echocardiographic features of a newborn baby with a heart murmur clinically considered to be innocent, and then to confirm their hypothesis that an innocent heart murmur in a neonatal period frequently has its origin in a pulmonary artery branch, which is what they thought, and then they wanted to define the time of disappearance of the murmur. So what they did was they took 5 months. Any baby born in their hospital within that 5 months who met that criteria had a murmur that was clinically felt to be innocent. They echoed. And then they echoed an equal number of babies who did not have a murmur to compare them. And again, these weren't cyanotic kids. These were healthy kids, innocent murmur. And they also echoed them 6 weeks out, 3 months out, and 6 months out. They only removed them if the heart murmur disappeared or the echo was completely normal. So they enrolled 50 healthy babies were enrolled in the study. They had 50 in the control group and 50 in the study group. And what they found, I'm going to summarize the studies for you, but really they found the murmurs resolved completely in 64% of the babies at 6 weeks, in 84% of the babies at 3 months, and in 98% at 6 months. And when they echoed these kids, these were innocent murmurs, they found almost everyone had a PFO. Whether they were healthy or they had a murmur, no murmur or murmur, the overall majority had a PFO. They found that PDAs were common, and something they called pulmonary branch stenosis, which I think is what Europeans or the British think of our PPS. So that was an interesting study in that in their hospital, innocent murmurs were found in 21 babies per 1,000 live births. And what they said was that this is a relatively common thing and there's not much you have to do. And the implication was you could probably follow these kids as an outpatient if you find a murmur without doing much else. Then, and this was thanks to Guarav, we had a study that just came across his email in Congenital Heart Disease Journal, 2018 May. The study is called Heart Murmurs and Echo Findings in the Normal Newborn Nursery by Michael Fenster and John Hawkinson. This was a retrospective review done from January 2008 to December 2015. All the patients were from one hospital, Meriter Hospital in Madison, Wisconsin. It's a very nice place. This was a single site, and they did the pulse oximeter screening from 2008 to 2010 on a single site. And then in 2011 and 2015, it was both pre- and post-ductal screening. The first thing I liked about this study, and Guarav, I may look to you for this one in ARC as well, is the introduction. The introduction discusses that although prenatal diagnosis of congenital heart disease is improving, almost half the cases are diagnosed after birth. And over and over again, no matter what you read, it showed that our prenatal screening is only about 50% effective. And then it discussed how different studies have found varying results, especially international studies, in terms of if you have what you think is an innocent murmur, should you or should you not echo the child. They had one study referenced by Singh et al. That 74% of newborns with a heart murmur had congenital heart disease, so they recommended all newborns with a murmur have an echo before discharge. Several other studies found congenital heart disease ranging from 22 to 86% of neonates with just murmurs. And they made a case that the variation is attributed to the different population studies, the variable definitions of congenital heart disease depending upon the journal. Their big point in the intro was there is not a consensus about this. What do you do or what do you not do? Which I think was their impetus for the study. So they also did an online survey of all the attending physicians at their nursery, their newborn nursery. And they asked questions about years of experience and specialty, which isn't as relevant for our talk. But their results are fascinating. So of the roughly 26,573 infants who were born and taken care of in the newborn nursery, 354 met criteria for this study, which is just a heart murmur. If the child had Down syndrome and a heart murmur, they were removed from the study. So a term healthy infant with a murmur. And Ark and I had discussed, did these kids screen low on the pulse ox or not? And it doesn't really say.
Well, actually, when I went back and looked at it more closely after our discussion, what it said was that if they triggered as a positive pulse ox screen, then they were sent to the NICU.
Yeah,
and
okay.
Those kids were eliminated. And so it was like you had said.
Okay.
Normal babies with a normal pulse ox screen.
And so of those kids who just had a murmur, 354 of them had an echo. Of that number, 163 were completely normal. And they said PFO, small PDA, and PPS, they considered normal findings, nothing to worry about. And then 160 had these incidental findings not requiring follow-up according to them. And that included small VSD, small ASD, mild valvular insufficiency. And we can get into if everyone agrees with that. But then 23 needed outpatient follow-up. 11 of those follow-up had no intervention needed. 2 of those, no surgical intervention, aortic stenosis. And then 10 were surgically repaired. And 3 were VSDs, 2 were coarcs, an AV canal, pulmonary valve stenosis, aortic valve stenosis, and Epstein's and a tetralogy of Fallot. And 8 of those 354 kids were transferred to the NICU. Interestingly, 3 on the follow-up echo were fine of those 8. 2 needed immediate surgery, and those are the ones I focused on. Who needed immediate surgery? 2 of them for aortic stenosis. And the rest were, 1 needed a balloon pulmonary valvuloplasty after discharge, 1 just did a follow-up for PDA, and 1 had a VSD closure after discharge. So that means of all those kids, 31 out of 354 who had an echo done solely to a murmur, which is about 8.8%, had echo findings in the newborn nursery that necessitated some sort of additional care, whether it was follow-up, whether it was surgery in the outpatient, or immediate surgery. 14 required surgery or interventional cardiology catheterization. 1 was treated for neonatal pulmonary hypertension, and 3 are still getting follow-up, and 13 had spontaneous resolution. So after I read that, I said, well, 8.8%, that's not a small number. If you're in the nursery and you're looking at all the kids you see who have an innocent murmur, or you think is a non-concerning murmur. So it left me a little in the dark as to what exactly the right thing to do is. So why don't we go around? Ark, we'll start with you. What do you do in your practice? What do you find is the appropriate steps?
It might not seem correct to say, but how I practice depends on where I am. And so when I'm in the NICUs, the level 3 and 4 NICUs, which are not exemplary places of utilization management, there's a lot of ordering of the echo, and not necessarily that I feel differently, but there are extenders, there's more colleagues, and so I tend to see more echoes ordered because the availability is so ready. When I'm at one of the level 2s where there is not ready availability for echocardiogram, those are the places where I personally am a lot more more thoughtful about whether I need an echo, because it's a big deal to get an echo at one of these places. And so the way I practice is, and I was always taught, what goes along with that murmur? What else is there? Is there cyanosis? Is there blood pressure instability? How are the pulses? And again, not to say that I'm not paying attention to that exam when I'm here, but when I'm at a place where the echo is not so readily available, I'm using all those things. And I find, and maybe Guarav can comment on this, that to me the exam, when the heartbeat is 160 times a minute, I'm not very good at telling if there's a split S2, or I think I can tell a single S2 when it's that fast, but I can't tell you anything about a split S2. So again, not to say that I'm not listening to them, but that probably is the lowest determinant on my scale. So I'm looking at blood pressure, I'm looking at the exam, I'm looking at the chest x-ray, I'm looking to see if I see what the pulmonary vascular markings are like, and I'm looking at the results of the pulse oximetry test. So that's what I use when I'm at a place where an echo is either not readily available or maybe not available at all, to decide, do I transfer this kid to the level 3 to get the echo? Do I try to get someone to come in to do this echo, and do I feel comfortable sending them home?
So let me follow that up before Guarav answers. Ark, how, at these level 2s where you're at, how hard is it, just so our listeners have an idea, if they're in a small site, if it's similar to what you're talking about, how hard would it be to get an echo?
So I've worked at places where there's just not availability at all, and then you would need to transfer in. At most places, there's either a cardiologist in private practice who is available maybe in the evening when past office hours, or, for example, one of our affiliated nurseries where I cover now, there's an echo tech who's been trained by the technicians here at Children's to do pediatric echoes, and then those echoes are transmitted electronically to Children's. But that echo tech, it doesn't work every day at this hospital. So again, it would be easy if I need it on the right day of the week.
Okay. Guarav, what do you think about this?
So one just extra comment to make on something Ark said, I think that is really useful, which is if you do have an X-ray or decide to get an X-ray, and whether we get one or not is a different question, but if you do have one, I think the other thing that's really valuable to look for is the aortic arch-sidedness. If you train yourself, you can see the aortic indentation on the trachea, and in most cases it should be on the left side of the trachea and indicating a left aortic arch. But if you have a kid with a murmur who has a right aortic arch, your index of suspicion for heart disease should go up a lot, because that's an unusual combination. And similarly, as you guys mentioned earlier, I think to make sure the listeners are in the same place that we're thinking of, which is what we're talking about is a baby who's otherwise healthy, who has no other abnormalities, because the other feature that you mentioned earlier with the Down syndrome also carries over to when you have babies who have multiple congenital anomalies, then the pre-test probability that kid has heart disease also goes up. I think the practical points that you guys made are really important. I don't think there's one right answer to how you approach that baby in the nursery, because a lot of it depends on where you are. I had the benefit after my residency training, my wife's a general pediatrician, and she and I traveled around the country and did locum tenens, and we got to practice in areas of very different size. And so we trained at Texas Children in Houston, which is a huge city, and training at the so-called ivory tower, if you will. You're used to sort of having a lot of luxury in terms of what you have available in your hands. But we had the opportunity to practice in towns of 3,000, of 10,000 people, and got to see what it was like to be there. And it's that exact question of what do you do when you have a kid who kind of looks fine, but just not completely fine, and you're just nervous about what do I do and how much do I worry about. So assuming the kid's passed a pulse ox test, I think for me, the one thing is really just what's your gut feel when you listen? Because I think we have to make one distinction here. If the kid has a moderate-sized paramembranous VSD, if the kid has a moderate-sized ASD, has a PDA, any of those left to right shunt lesions, if you don't diagnose that on day of life 0 or 1 or 2, and you diagnose that, and it gets diagnosed on day of life 10 instead, that's going to be perfectly fine. Nothing bad's going to happen, okay? So you could argue that's a quote-unquote miss because you didn't diagnose it when you could have diagnosed it. But I view it as, what do you need to worry about that if you send this kid home, something bad's going to happen before you have the opportunity to really get this kid taken care of in the right way? And left to right shunt lesions are not what I worry about, okay? And so as you saw in that paper, I think one of the key take-homes there was really the kids that were urgent were the 2 kids with aortic stenosis. So when kids have murmurs in those first 48 hours, the 2 innocent murmurs are PDA murmurs, closing PDA murmurs typically, and peripheral artery branch pulmonary stenosis, or what we typically call PPS, which is a murmur of relative pulmonary stenosis where you're trying to put a lot of blood through pulmonary arteries that aren't quite big enough, and so you get a little bit of acceleration of flow. And remember that a murmur is sound related to increased velocity, so you have to have increased velocity somewhere, and that's where that comes from. The pathologic murmurs we're going to talk about really are due to either 2 things in the first couple of days of life. One's VSD, but that's unusual because the VSD requires you to drop your pulmonary vascular resistance for it to have high velocity. And oftentimes newborns have elevated pulmonary vascular resistance. So the textbook classic story for a VSD is either no murmur or just a kind of insignificant murmur in the first couple of days of life. And then when they come to the office for their 1-week check or their 2-week check, all of a sudden they have a really loud, prominent murmur. And you say, oh, that's a VSD then. But if you call me and say, I've got a 4-hour-old who looks fine but has a really loud murmur, then my money's going to be on some kind of semilunar valve stenosis, so either aortic stenosis or pulmonary stenosis, and any type of heart disease that could go with that. So, for example, tetralogy of Fallot, when you hear that murmur in the first day of life from tetralogy of Fallot, the murmur you're hearing is the pulmonary stenosis component of it. And so it's sometimes difficult to tease out whether that's pulmonary stenosis due to tetralogy of Fallot with a normal SAT, or whether that's isolated valvular pulmonary stenosis. But the good news is you don't need to make that determination when you listen. You just need to be able to listen and say, that sounds really abnormal. And so I think the first thing that your listeners should do is trust their instincts and trust their experience, because you guys out there, you have the opportunity to listen to brand new babies in those first 6 to 12 hours of life way more than I do. I don't listen to 6-hour-olds anymore because someone's calling me to listen to them, which means it's well beyond that. And so after you've listened to hundreds of babies and you listen to that one where you say, this sounds really unusual, that spidey sense should be absolutely respected. And so if you feel that and everything else looks fine, for me a little bit depends on what do you think you're hearing. And if you're hearing that really harsh, loud-sounding murmur very early in life, i.e. the first 6 to 12 hours, I would be more suspicious for aortic stenosis or pulmonary stenosis. And those are the ones that I would have a lower threshold to sort of think about getting your next level evaluation in some way. And as Ark said, a lot of it depends on where you are and what you have access to. Remember, I think in this day, much more so than when I was in the place of practicing in small towns, today we have, echo is a standard modality. And so pretty much if you have a hospital where they do echoes on adults, you can probably get somebody to put a probe on, at least get some basic pictures. And so if you're far from a center where you're thinking, oh my gosh, I'm going to have to ship a kid hours away to get them an evaluation, is it really warranted? One thing to contemplate is your nearest pediatric cardiology center, and do they offer what we call teleechocardiography here, where we have a service here at UPMC Children's where we read echoes from all across the area, from Western PA, where techs, not pediatric techs, but techs are doing echoes at community hospitals all around, and they'll send that to us, and our echocardiographers will review them, because that's going to at least give you the basic screen of, is this a normal 4-chambered heart? Does everything look basically intact, or is there something here that's more concerning that would make you feel better about that decision to transfer that kid?
Can I ask Guarav a question? Yeah. So in using the example of these kids in the study, the 2 who had aortic stenosis, don't you think and they had a normal pulse ox test, don't you think that they would have presented at some point with, so is that the timing of the pulse ox test? If you're suspicious and you had a normal pulse ox test, should you go and repeat it, even though they pass it at 24 hours? Should you go back and do it at 48? I mean, don't you think at some point we would have seen something on that?
Maybe the challenge specifically with aortic stenosis is you're compromising the output from the left ventricle to the body, and if it's very severe, then you might rely on the ductus to provide some cardiac output. And in that case, you should fail your pulse ox test, because you should see a difference between the preductal and postductal sat. Obviously, the algorithms for pulse ox screening are designed to try and sort of account for all the initial transitional changes, which is why we wait to do it, as you mentioned. I think if you had a kid, from a practical perspective, I sort of always think about risk and benefits. And so if you had a kid who passed their pulse ox screen on day of life 1 and you're seeing them on the second day, and they still have a really loud murmur that bugs you, I don't have any problem with you saying I'm going to do it again at that point and saying, well, let me see if they still pass. AS, I think the reason we as cardiologists get AS and coarctation are the two things I get most nervous about in brand new babies. And the reason is, if we think about fetal physiology and that transition, right? So the PDA is open in utero, and then when you're born, the PDA is going to close sometime in the first 14 days of life. So if you, for most babies, if you examine that baby on day of life 0 or 1, and the PDA is still open, and they have a coarctation, let's say, or they have mild AS that doesn't sound like a whole lot to you, so you're not sure if it's something, their femoral pulses are going to be perfectly normal because the PDA is open and they've got perfectly fine lower extremity cardiac output. But when that PDA closes, whether it's tonight or hopefully not after they go home, now all of a sudden they're going to develop diminished femoral artery pulses and really have trouble. And so that's what we all worry about, is that baby that you examine and they were perfectly fine, and then they go home and now their PDA closes, their ductus closes, they start developing poor cardiac output and cardiogenic shock, and now they're going to come in extremely sick. And so one of the things I teach our residents and fellows is that I can't overemphasize enough the importance of making sure you believe the femoral pulses are completely normal. Because if we're going to try and pick up the heart diseases that matter in those first 2 weeks of life, ductal-dependent systemic blood flow from a coarctation or aortic stenosis are important. And one of the ways you pick that up is if you can't feel femoral pulses, that's a reason enough to call the cardiologist. And I'll jump in with a story, if you don't mind, which is it's a true story. When my wife and I were in a town about 2 hours away, 2.5 hours away from a major medical center, and it was in the north part of the country, so weather came into factor because it was about October, November. And my wife was examining a baby who was about 10 days old in the office, who was doing great and thriving, and everything was great, but she just said, I just can't feel the femoral pulses very well. And she asked me to come and take a look also, and so I came as a sort of second opinion, and I looked at the kid, and we tried probably for 15 to 20 minutes and just couldn't feel like we really felt femoral pulses in this baby who was less than 2 weeks old. And I had an interest in cardiology. I was going to do a fellowship, and so I said, well, let me call a cardiologist over at the center and see. And I have to admit, I was a little nervous, like they were going to yell at me like I was an idiot, like what was I doing? And the gentleman was so nice to me, and he said, he heard the story, and he said, tell you what, it's about 3 o'clock, the weather's turning bad tonight, snow's coming. I don't want to make you drive this kid right now. It's making me a little worried. I tell you what, we'll see him tomorrow morning at 9 in the morning in clinic. But you tell that family tonight, anything happens, that kid doesn't feed right, that kid doesn't act right, that kid's irritable tonight, they come to the emergency room tonight, we'll come get him. But and now knowing where I am today, I 100% understand why he said that, because not feeling femoral pulses could be the first sign that their duct is closing and that they're going to have trouble in the near future. Now, the good news is most times that somebody says that, it turns out to be nothing. But that's one of those things that may seem to some people like a very soft indicator, but to me that's absolutely legitimately a reason to call a cardiologist and say, hey, this is what's going on with the kid. You know, we had done pre and post blood pressures and they were not obvious. There was no obvious gradient there. So nothing else screamed out that there was obstruction to the arch, but the fact that we couldn't feel it really bugged us. And that's something that I think to watch for. And so in addition to the babies passing their pulse ox screening, I think one thing to be certain of as you examine some of these babies is make sure that you're happy with their femoral pulses and that they're normal.
So let me ask this for anyone in a place that doesn't have readily available access to echo. How helpful is any of the other studies? Like an EKG, for example, is one I read on over and over again. And basically this consensus I read, and I want to see if you agree with this, is unless you have a left ventricular hypertrophy in a newborn infant, your EKG isn't going to be as helpful as you'd like it to be for any of these types of lesions we're talking about in a healthy newborn with just a murmur.
Yeah, I think that's probably true. I think that, I was raised in that era of everybody with a murmur gets an EKG, a chest x-ray, and 4 extremity blood pressures once upon a time. But I think if we want to be analytical and evidence-based, I think you'd be hard-pressed to argue that it's cost-effective to get that an EKG is going to give you the answer, because ultimately what you're going to rely on is someone's exam, as Ark said. It's really the exam, and so the level of concern the exam rises, and it's am I worried about this murmur or not? And one of the unfortunate things about this is, like other areas of medicine, I think it takes a certain amount of experience and knowledge to get there. And the example I always use is, as pediatric residents, you have to look in hundreds of kids' ears to understand what the range of normal variation is in the way that tympanic membranes look and which ones are actually infected and which ones are not. And I think similarly, you have to just listen to tons of kids in the early phases and see which ones are this murmur I'm not terribly worried about, or this one sounds different. And that sounds different. You have to build your own internal encyclopedia of what sounds okay before you can really identify this sounds different, I don't like it.
I think I do that. Like I said, I cannot tell a split S2 at 150 beats a minute. But I think, in my experience, figured out what a single loud S2 is. And I rely, when I'm out at these outside places, I do rely a lot on a chest x-ray. I kind of see it as a poor man's echo. So I look at it, and I'm looking in particular for the vascular markings, not just for heart size, but I'm really looking at the vascular markings, and it can be hard if there's RDS or any kind of lung disease. But I feel like when I see those black lungs, then I know that, okay, I might need to call in some help and maybe think about prostaglandins, because to me, that's a ductal-dependent lesion. That's blood not getting to the lungs.
All right, we're going to move to our next segment, but in between, we, of course, have our corny joke segment to break things up. So I hope you all brought yours. So I'll start. Ark, what do you call security guards working outside of Samsung shops?
I have no idea.
Guardians of the Galaxy.
So horrible.
I love that. All right, you're up, Ark. Do you have one with
for the
you?
joke? I only have one, but
Okay.
but I do believe it to be a good one. What did the duck say to the bartender?
I don't know.
Guarav,
Don't know.
put it on my bill.
Guarav, wait, why don't we? You want to save yours for later?
Sure.
We'll do that. I'll do one more that I really like, and we'll move on. Why did the golfer wear 2 pairs of pants? In case he got a hole in one.
Oh.
All right, we're going to move on now to discuss. We're going to segue in the pulse ox and newborn period. Why do we use it? Why do we do the preductal and postductal, and how does it help? Now, for this, I have to turn the pages of my little yellow pad here. The article I am going to discuss is in Pediatrics in Review. It's called Pulse Oximetry in the Neonate by Philip Roth. It is from 2016, and the month was September. And this was a short article, but it really kind of brought home what I needed it to. So I'm going to tell you what my summary of it is, and then we're going to talk to our guests. The point of this, or how you do it, is you put the placement of the first pulse oximeter probe on a preductal site, usually the right hand, and the second probe on a postductal site, usually either foot. And it allows detection of ductal shunting, which occurs in 90% of cases. Well, it allows detection of a couple things. The one of the things they talked about was primary persistent pulmonary hypertension of the newborn. So one of the things it also helps with is critical congenital heart disease in detecting either primary pulmonary hypertension newborn or critical congenital heart disease. In the article, they define that as lesions that require intervention in the first postnatal year for survival. And they say it counts for approximately 25% of congenital heart disease cases, but it may not be evident initially because of an incomplete transition from the fetal circulation. And they went over again that fetal ultrasonography detects only about 50% of critical congenital heart disease, particularly lesions with single ventricle configuration. The overall reliability is limited, and it has become the standard of care. So the sensitivity and specificity of this is between 75 to 80%, specificity is greater than 99%. The negative predictive value is greater than 99%. And they want to talk about even with fewer than 1% of neonates who have false positive screening results for this, when you perform an echo on these kids, you usually get some sort of other clinically relevant condition like pulmonary hypertension. And the lesions that this particular screening may not detect well is aortic outflow obstruction, which can present later than other critical congenital heart diseases. So from my understanding of this, and I'm going to turn to my expert guests on this, this is something that can help you detect these critical congenital heart disease lesions or persistent pulmonary hypertension of the newborn. And now you're going to have to forgive me for this, but this is an area that I've always forgotten. PPHN has been a bane of my existence when it comes to cardiology. So what I understand it to be is a basic failure of the pulmonary artery pressure to decline postnatally. And that's because the pulmonary artery pressure, you have pulmonary vascular resistance and pulmonary blood flow and wedge pressure. And the pulmonary vascular resistance stays high, and that's one of the reasons you get PPHN. So your net effect is a right ventricular dysfunction as well as right to left shunting across the fetal channels, like the PFO or the ductus arteriosus, and then you get decreased pulmonary blood flow. Does that sound right? Good. For our listener. Oh, go ahead.
So it does, although most of the time you're not going to diagnose PPHN based on a 24-hour test, on the 24-hour pulse oximetry test. So those babies so the babies who have critical PPHN, so not just some physiologic increase in so persistence of increased pulmonary vascular resistance, so more physiologic. Those you might find that, but the babies who have critical PPHN, those are the babies that are presenting with hypoxia or hypoxemia and are ill right out of the delivery room. So then the
I think sorry not to jump in, but I think they're going to fall more in the last category we're going to discuss, where we're talking about that cyanotic infant, and that's the place where sort of, as Arc saying, severe PPHN is in the differential for that. Whereas the pulse ox screen failures, since you're not doing that till 24 hours of life to let them transition, you might find those people who have a little bit of persistence of elevated pulmonary vascular resistance, but are not clinically struggling because of that.
And so just for our listeners, if you're listening and you want to know what we're talking about for the screen, I'm going to run through the CDC screen very quickly. And just like Guarav said, you're in the well baby nursery, you have to be greater than 24 hours of age, or the child's got to be shortly before discharge, less than 24 hours of age. You do the screen like we said. If you have less than 90% of pulse ox in the right hand or the foot, it's a positive screen. If you have greater than 95% in the right hand or foot and less than a 3% difference, less than or equal to a 3% difference between the right foot and the hand, right hand and foot, it's a negative screen. And where it gets tough is if you have 90 to 95% in the right hand and foot, or greater than 3% difference between the right hand and foot, you repeat the screen in an hour. If you have the same thing, you repeat the screen, and you keep repeating the screen until you get a positive or a negative screen.
Up to 3 tries.
Up to 3 tries. And then if you're still going, it's a positive screen.
And for the listeners to remember, and obviously we can't draw this for you, but the idea being for the pre and postductal, remember the PDA is open when you're born, and the PDA connects the main pulmonary artery to the aorta. And so if you have any condition that results in increased pulmonary vascular resistance, you may shunt blood from the pulmonary artery through the PDA down to your lower extremities. And so the most common abnormality that you'll see in that case with a positive due to the differential is because you're shunting deoxygenated blood through the PDA to the lower extremities, and your lower extremities will be lower saturation by the more than 3% they use. And that usually indicates the presence of something that's causing right to left shunting at the ductal level. And that can either be a pulmonary related cause or a structural congenital heart disease related cause. But in either case, that differential being more than the 3% they recommend is the trigger for you to say, something's just not quite right here. And remember that all of these things are based on probability theories of what's most likely. And so there's very few things that are 100%, but probabilistically, if you have less than the 3% difference, then you're unlikely to have something significant.
So, and along those lines, if you have a positive screen, there's less issue here. You go get an echo. I'm
Yes.
right there.
Yes.
Okay.
I think the practical challenge that your listeners face and people face is when you're in one of those centers, and Arc, I'm curious to hear what your thoughts are. If you're in one of those centers where echo is not readily available and it's hours away and the kid looks great, how do you feel about if they fail? Do you feel like that's a kid that has to be transported, or close outpatient follow-up and cardiology evaluation in a day or two? And this, I think, is one of those differences between practical medicine and perhaps by the textbook medicine.
Yeah, right. So honestly, I feel that I would be hard-pressed to say, go on home and we'll see I'll have you see the cardiologist on Friday. That said, it's happened many times. In fact, just happened to me this week, not about cardiology, but I needed somebody to return to the hospital, and they don't have gas, and they don't have money to get gas. Mm-hmm. And so those things always come up. And then we all struggle in those circumstances. But yeah, I think with an abnormal pulse ox screen, even though I'm confident of my exam, and even though knowing that there's about 25% false positive, I'd be hard pressed not to refer immediately.
I think that's probably true. I think that really getting an echo in some way, shape, or form is the right thing to do next. And so if you have capability to get it in your institution, that's great. If you don't, you could send that kid in via transport. And the last thing is, as I said earlier, do you have the capability to perhaps get echo images that you could send to somebody to review to help you make that decision? But I think, to me, the failed pulse ox screen necessitates the next step in the chain, which is getting an echo.
And so I think, if I'm just thinking of worst scenario, that for whatever reason I can't get a remote echo, or I can't, for whatever reason, get them to the center, I don't think I would discharge that kid. I think I would keep that kid in my nursery until I could get an evaluation one way or another.
Okay, so in terms of bad weather or difficult travel for one reason or another, that kid stays in the hospital and you get them an echo as soon as you can.
Correct, because you say, well, what are you going to do if you don't even have a cardiologist? But what you're going to do is, if that duct closes and that baby begins to get ill, I can put in an IV and support cardiovascular circulation. I can always pick up the phone and talk to a cardiologist. I can start prostaglandin, although I'm sure we'll talk about that, which is not as easy as it sounds at an outside place where the pharmacy is not used to mixing those kind of drips. But I have things available to me to do which that baby would not have at home.
And Art, that's a perfect segue, because we do have to move on. And what we're going to talk about now is the dreaded cyanotic infant. Baby is born and then becomes blue, and they're in your nursery. We have to differentiate this a little bit, because the differential is huge. This can be sepsis, this can be methemoglobinemia, this can be lots of different things. We're going to focus on that cyanotic infant, where it's either a primary respiratory disease, congenital heart disease, or severe PPHN. And that group, and how do you differentiate that? And the way I have learned this and kind of read this, one of the first things you do is what's now the hyperoxia test, where you take this infant and you put them on, you get a partial pressure of oxygen through usually an ABG, and you get them on 100% oxygen, and then you recheck that partial pressure of oxygen. And in numerous papers, and then I'm going to go through more references when we're done, what I've found is, if the partial pressure of oxygen rises to above 150, you're probably dealing with something like PPHN or a pulmonary disease. If you do not go up on 100% oxygen, then you're probably dealing with a congenital heart disease. Does that sound right?
So the baby with PPHN may also not get their PaO2 up over 150 just because of the process, which is increased pulmonary vascular resistance. So either way, you're not perfusing the lungs, and you're not oxygenating, or you're not getting blood flow to the lungs to be oxygenated. So those two things can look the same. So it can be difficult then to decide, is this baby not getting up over 150 because he's got a congenital heart lesion or because he's got PPHN?
And I think about it slightly the opposite, which is, if you get over 300, then you probably don't have significant heart disease as the cause of your cyanosis at that point then. And the other simple thing I look at when I see babies and newborns who are significantly hypoxemic is simply, what's their work of breathing? Because the baby who has a SAT of 80 with no increased work of breathing who looks super comfortable, that sure smells like heart disease to me. Whereas those kids who have neonatal pneumonia or significant pulmonary cause and have a SAT of 80 usually have some increased dyspnea and work of breathing, because they're not used to being at 80, and they don't want to be at 80, and they're struggling to get there. And so that's often a sort of simple clue of how ill does that kid look, and is it match their SAT or not.
So and that's how I teach the med students and residents. Without even touching him, is he working hard to breathe? Although the caveat is that every once in a while, a baby with meconium aspiration will have congenital heart disease, or every once in a while there's that baby with TTN who has congenital heart disease. So it's not 100%, but for the most part, baby in respiratory distress is not going to have a primary cardiac lesion.
And then once you have your hyperoxia test and you're thinking this is either PPHN or congenital heart disease, traditionally there was the hyperventilation test after that, but from what I've read now, we're going right to Doppler, or echo, to really check what this is. And especially in a bigger institution, that should be easier to get. Does that sound right?
Yeah, absolutely, yes, because even in the kid without structural heart disease, as Ark said, the kid with bad PPHN, you'd like to know what's the RV function. And is the RV handling it? Do you need something in addition to airway support? Do you need inotropic support because of ventricular dysfunction? So I think again, to me, that hyperoxia test triggers just similar to the way the pulse ox screen did, which is when you fail that, you now need an echo to help you take the next step.
With hyperventilation, bringing that PCO2 down, you're compromising flow to the brain if it's prolonged, and so it's the sort of thing that you don't want to undertake and just continue for too long. So I think, again, if you have a kid who's in that kind of trouble from PPHN or a congenital lesion, you're probably, to Guarav's point, you're going to need that next step. You're going to need an echo.
Now, Ark, what I'm real curious about is for these kids, they're born in an institution that doesn't have echo. And they surprise you, because they can surprise you. You don't expect them. Typically, if you know they're coming from prenatal ultrasound, you're going to have them deliver at a big institution that has everything ready. But if you're in a small place, they come out and they surprise you, you've done your hyperoxia test, you know there's likely a congenital heart disease. From a management perspective, right then and there, what do you do?
So again, in the NICU, we always think about sepsis first. And so when we have a baby who's in distress, and right or wrong, but we tend to always put them on antibiotics first. Everything's happening at the same time. So that baby would still get, particularly if you're at a place where you don't have your echo yet, that baby would still get a sepsis evaluation. So would get a blood culture and get started on antibiotics, because we know that PPHN, acidosis, and hypoxemia can trigger this persistent increased pulmonary vascular resistance, and so sepsis is a cause of acidosis. So to begin, just make sure that you're still doing your sepsis evaluations. Next, like I said, those are the times. So that next year, ABCs, right? You're controlling the airway, providing circulatory support in the form of fluids. And again, that's where I use that chest X-ray. That helps me a lot. Am I seeing black lung fields? Am I seeing a pneumonia? And the things that are hard to diagnose prenatally, like total anomalous pulmonary venous return, or the things that look like pneumonia. So it's not always helpful, and and that's happened to me at one of these hospitals where a baby that looked positive. 100% O2 test, looks like pneumonia, cannot get to oxygenate above 150, and turns out to have total anomalous pulmonary venous return. And then the next thing is, so most of the time, if the baby is in that kind of trouble, I'm likely going to be working to transfer him out, regardless if I think he has cardiac disease or not, or he just has significant PPHN. So the question then becomes, if I think he has cardiac disease, and I think it's a ductal-dependent lesion, so if I think it's a mixing lesion, then the prostaglandins aren't really going to have much effect, right, Guarav?
Mm-hmm. Yeah, correct.
But then do I start the prostaglandins? And I've kind of changed my thought about this. Earlier in my career, I was like, yeah, this is what we're supposed to do. Let's get the prostaglandins. What I've come to realize is that there are pharmacy errors at a place that's not used to mixing drips for that size of patient. And, one time I asked for prostaglandins at one of these hospitals, and they sent me the prostaglandin gel that they put on the cervix to induce. So I'm like, I don't, much as I'd like to rub it all over him, it's not going to work. So I've changed completely on that. And in fact, the transport teams now will come with the prostaglandin. So
they'll come ready to go.
They'll come ready to go. So, and maybe Guarav can answer this. So do you think that waiting for that team to come with the prostaglandins affects the outcome of the baby, do you think?
So to me, I'm going to cop out here, and I'm going to say it all depends on how sick your kid is, right? So I think it's one of those where you sort of alluded to it. If you have a kid who's got a SATA 85 and kind of looks okay, you just can't get it above 85, but they otherwise look not bad, and you get your basic breakdown, and they're not acidotic, and they're doing okay. There's no rush. You don't have to start that kid on prostaglandins. As you said, that kid probably has a mixing lesion. That kid probably has AV canal defect or something like that, where they may be somewhat cyanotic, but they're fine. They're not in extremis. But if you have the kid who's super sick, who's acidotic, who's doing poorly, who's 78%, and they're in trouble, and you've done everything you can in this place, and you're just waiting for the transport team that's 2 hours away, at that kid, I think it's fine to start prostaglandin. I know, Tony, you're going to talk about the article that came out of Texas that looked at the sort of availability of prostaglandin. I think it's one of those where anecdotally, we've all seen kids who came because they were in a place that didn't have prostaglandin available and didn't get it started there, who ended up having ductal-dependent lesions, whether they be ductal-dependent pulmonary blood flow lesions where they have blackened lung fields, or ductal-dependent systemic blood flow lesions where they had cardiogenic shock because of a closing ductus, who struggled because they had other end organ injury from the significant time. And so we've all seen that anecdotally, and that's what you want to avoid. And to me, it's about how clinically ill is the baby you're taking care of in the first place. And I think if that baby's ill and you've done A, B, C, and you haven't gotten any headway, you've already called your transport team, you know you're moving this kid, but now what else can you do? If you have prostaglandin available, I think it's a good idea to start. I think ignore, as you said, med errors are totally a thing that we have to be honest about, because when you use a medication that no one is familiar using, it's very easy to imagine that it might not be mixed correctly. But that notwithstanding, the other sort of people talk about, are there certain lesions that prostaglandin might make worse if you started it? And the answer is, well, maybe so. But in that scenario, I think you'd rather err on the side, if you're not sure what this is, to start it, because it may dramatically improve that child's clinical status at that point.
Yeah, so as I'm listening to you talk, I realize that my thinking has changed, but I have the luxury of, even when I'm at an outside hospital, I'm a 15-minute helicopter ride from here. Right, so I think about it differently than if I'm 3 hours away, like you found yourself. And so maybe if any of the listeners are in that sort of situation, then I proactively would go to my pharmacy and say, hey, what do we have? If I call for this urgently, like what could you do ahead of time to prepare for that maybe once a year kid that's going to come in, but you're going to be so happy that you prepared. And you have confidence that what you asked for is actually what they're going to send you, and it will not come in a gel form.
Right, and I think that's a great point, because I think you have to know where you are and what you have available to you. And so my wife practices at a place that does not have a level 3 nursery, but if they wanted to, when they call to send somebody, a transport team comes from ground and they're able to be there within 20 to 30 minutes. Right. So in those scenarios, honestly, by the time you activate the ground team, you start doing your other stuff, they're going to be there. Right. And you're going to be confident that they're going to bring prostaglandin mixed in the right concentration because they're used to using it. But if you are in one of these places that are hours away from your nearest sort of tertiary children's hospital, then you might want to explore saying to your pharmacy, look, I know this might sit on our shelf for a year, 18 months and not get used, but if we need to use it, it could be absolutely life-saving for a baby. So let's talk about what we can do. And I'm not an administrator for pharmacy, but you could imagine a scenario where you say, gosh, is there any way we can stock this? And then 6 months before it's going to expire, we sort of talk to our local children's hospital and say, hey, can you guys use this? Because can we, I don't know how you do it, but it's just one of those where if you're that far out, then it does definitely have a role, I think, because it can make a difference.
Well, along those lines, let's talk about our next article, which is exactly what we're discussing. Prostaglandin availability and association with outcomes for infants with congenital heart disease. This was in 2016 in Pediatric Cardiology. The authors were Brady Muffett, M-O-F-F-E-T-T, Joshua Garrison, Amy Hang, Shane Morris, et al. And this was an interesting study. It was a retrospective study done from 2007 to 2012, looking at all children admitted to the Texas Medical Center, Texas Children's Hospital, who received prostaglandins. And Texas is a state like we're talking about where there's a big cities, but there's also huge areas of rural locations. And these are small hospitals in the middle of nowhere. And they first figured out who was coming to their major medical center from these outside hospitals who had a congenital heart defect. The inclusion criteria was they received prostaglandin for a ductal-dependent congenital heart lesion as determined by the referring or transporting team. Their outcome measures were hospital length of stay, postoperative length of stay, mortality, as well as some lab values on admission, lactate, creatinine, glucose, O2 sats, acid-base excess, and pH. And they wanted to determine the proportion of hospitals that perform delivery of infants in Texas that stock prostaglandins in their pharmacy, and then they wanted to investigate the association between the birth hospitals, prostaglandin availability, and clinical outcomes in the infants with these ductal-dependent congenital heart disease lesions that were ultimately transferred to their center. So they found about 50% of the hospitals were stocked with prostaglandins that performed these deliveries in 2011, which was about 80% of all the births. patients who were born in a hospital with prostaglandin were more likely to have a prenatal diagnosis of congenital heart disease, which makes sense. You're going to send those kids there, and were admitted to the institution at the referring institution at a younger age. And then half of the hospitals with obstetric services, representing about 21% of all the births in the state, do not routinely stock prostaglandin, even though the AAP considers it a useful drug to have available, like we've been talking about. And then the patients that were born at the hospitals that did not stock prostaglandin did have significantly greater serum lactate and creatinine on admission to the referring hospital, but it wasn't associated with an increase, a change in length of stay, post-operative length of stay, or mortality. So not having prostaglandins at the site where the patient was born really didn't change mortality or length of stay for these infants, even though when they came to the referring hospital, their lactate was greater and their other lab values were off. And they also say the limitation of the study, it's a single center, it's one place in Texas, even though they have big areas of rural communities, that does limit it. But it raises an interesting question. I mean, what you're saying, I can totally agree with. What do you think about this, Guarav?
No, it's a great question. I think, again, as I said earlier, I think anecdotally, we can think of those babies who have showed up who weren't on prostaglandin ahead of time and then got prostaglandin on arrival, but had increased serum creatinine, increased lactate. In my anecdotal experience, I think it does impact overall length of stay in the sense that you're going to wait for that end organ injury to resolve before you're going to consider surgical intervention. And so if you discover that critical coarctation that needed prostaglandin and they had elevated serum creatinine, elevated LFTs, increased lactate, you're going to put them on prostaglandin, put them on inotropic support, let that wash out and make sure their end organs are recovered before you then go to put them on bypass to do surgery. Whereas if you discovered that and they were on initially. So it's one of those that it is counterintuitive to me to know that, and I'm not sure if it's an effect of sample size in the paper or if, did the time that you would wait for that to happen sort of coincide in the group that got prostaglandin with their usual waiting time to surgery anyway. So I think a little bit of it is institution dependent. That being said, I think none of us would want to have those kids who have higher creatinines and higher lactase to begin with if we can avoid it. So I still think that's the goal. But Tony, what you're alluding to is a bigger picture problem, which is if you're in a small hospital, convincing somebody that it's worth the money investment because someone's going to say, well, it didn't affect the outcome, so why should I have to spend that money? And I don't know the cost of a vial of prostaglandin, but I know it's not cheap.
Arc, anything to add?
Yeah, so I guess when I looked at that paper, I don't know if those were transient increases in the creatinine, because I understand what Guarav is saying, that you wouldn't send a kid home who had persistent kidney injury. So I don't know if that was something that quickly resolved once they...
Yeah, usually when you see it is so, and we see the same thing in babies who went home and then came back to the hospital with a ductal-dependent systemic blood flow lesion. But what happens is if they didn't get prostaglandin in the resuscitation, they got sick, then usually they get acidotic, they'll get some degree of liver dysfunction and elevated transaminases, they'll get acute kidney injury and elevated creatinine and increased lactate. And then once you put them on prostaglandin, open up their duct, and then consider inotropic support, for those babies, as we all know, they're very resilient. And so usually for most of those kids, within a few days, we'll reverse all of that. And their creatinines will come back to normal, their lactates will wash out, their transaminases will return to normal. And then you say, okay, and their ventricular function, if it was compromised because of the closed ductus, will usually return to normal. I would ballpark that without evidence to say that happened. Without evidence, I would ballpark that as happening usually within a few days for most babies. And then you'd say, okay, let's go ahead and do the surgery now. So as I said, maybe the reason it doesn't affect length of stay is because if you diagnosed a baby on day of life 0 to 1 with the coarct and they didn't have the increased serum creatinine, you might still wait a day or two to let them sort of settle out before you operate on them. But if they have injury, you're going to definitely want to wait to make sure that before you put them on bypass and subject them to another insult, that you have let them return to baseline.
All right, we have to wrap this up. So I'm going to start by saying thank you to my guests for being here today. I really appreciate it, Arc and Guarav. This was great. This was a topic I was dreading, but I think it went over well. I really appreciate your time. Thanks for being here.
Thank you.
Thank you very much. One last thing to ask you. Who serves the food in the restaurants on the Death Star?
I don't know.
Darth Waiters.
How did Darth Vader know what Luke got him for Christmas? He could feel his presence. All right, let's do our wrap-up. So, I thank my guest. I do want to do acknowledgments and thank, of course, Dr. Megan Keene Tarchichi, who helps me with everything. Again, for all the listeners, there's free CME available if you follow the link on the podcast description. Thank you to our division of Pediatric Hospital, the Paul C. Gaffney Division of Pediatric Hospital Medicine at Children's. As always, for everyone, I want to apologize again for how long it's been. I promise to get back in the swing of things now. And if you're thinking about applying for a hospital medicine fellowship, please think about Children's Hospital of Pittsburgh. The fellowship director there is very nice. And if you have any suggestions or comments for a podcast, compliments or anything, please feel free to email me at tony.tarchichi, TARCHICHI @chp.edu. We'll see you next time. Thank you.